All right. So we'll give it a couple minutes. Let people kind of transition.
How are you recording these days? Just on the laptop?
And then I just edit off later.
Oh, that's so cool.
We don't get to record too many because a lot of the basic science talks, people don't want their proprietary or unpublished data online, but it seems like this is more educational. So if you have a couple more minutes for Relevance,
Yeah. What? Do we have to have conferences down here? Yeah. It's so long.
You can talk to me.
I'm glad I ran into Mark on the show.
I text page too yesterday because I was like, I want to make sure they know where they're going.
Yeah, I just figured I thought I'd come here.
Yeah. Because I think R110 just has like a home beacon for everybody. Like everyone assumes they're there.
Yeah. Yeah.
That blood pressure went about 30 points driving down there.
You picked me up with that, right?
Yeah. So I'm 2 days ago in joint, 1 day research. Yeah. I'm surrounded by women. We got 3 cats, they're all female. 1 dog. I'm totally out there. No chance. I had a younger brother and a younger sister. There wasn't here. Yeah, so it's actually
Yeah, I didn't realize that. I know, I don't think I signed up for it. Yeah, but I wonder if I think technically you're still supposed to sign up. The problem with us is apparently that it's zero.
my pleasure to introduce Dr. Lawrence Ho, who's a clinical assistant professor in the Division of Pulmonary Medicine, Critical Care, and Sleep. There's as many ILD docs now as there are sleep docs. I don't know why ILD doesn't get the same billing as sleep, but anyway. Lawrence did his medical school at the Northeast Ohio School of Medicine, which he tells me is one of the only two programs in the country that actually has a 6-year European-like program to go through undergraduate as well as medical school. He did his residency here at the University of Washington and did a fellowship at Stanford in pulmonary medicine. He came back and did a 1-year ILD fellowship with Dr. Raghu, and he's been on faculty ever since. And great colleague, very smart physician, and it's been a pleasure to work with him in the ILD clinic. And look forward to hearing what he has to teach me about ILD today.
Thank you. All right. Thank you for that kind introduction. So again, my name is Lawrence Ho. I'm one of the pulmonologists in the ILD clinic. These are my disclosures here. And these are the factors that I want to talk about today. So, and this is an update on autoimmune and fibrotic lung disease. I want to review the guidelines for the diagnosis and management of IPF, that these have been updated several months ago. And I want to use this sort of as a jumping off point to discuss autoimmune lung disease and talk about some classifications that we have, specifically this term IPAF, Idiopathic Pneumonia with Autoimmune Features, that will look at a subset of rapidly progressing interstitial lung disease. This is the clinically amyopathic dermatomyositis with MDA5, and then we'll talk about treatment. Treatment for IPF include these anti-fibrotic therapies and reflux, and we'll talk about how we can sort of extrapolate that into our patients with autoimmune lung disease. First, what is IPF? IPF is a progressive fatal lung disease of unknown etiology where the fibrosis is limited to the lungs. And the diagnosis of IPF requires exclusion of other known causes of interstitial lung disease. Presence of a usual interstitial pneumonia pattern, UIP pattern, on HRCT scan in patients who have not undergone a biopsy, or combination of HRCT and surgical lung biopsy patterns. To understand IPF more, let's look at a guideline. These are guidelines dating back to the year 2000 here. So over the last 18 years, these are the guidelines that have been published of IPF. First, guideline in 2000, and this is actually not even a guideline, this is just a consensus statement. The first real guidelines were actually in 2011. This was the guidelines for the diagnosis and management of IPF. They've been updated in 2015 and 2018. 2015 mainly focusing on the treatment. 2018, several months ago, this is focusing on the diagnosis. Let's look at this past, which is a paper here in 2000. And remember, this is a consensus statement. From a diagnostic standpoint, the suggestion at that time was the diagnosis was made with the surgical lung biopsy showing a UIP pattern, or if there's no biopsy, you would major and minor criteria. The major criteria would fit all of these are exclusion of other known causes of ILD, a restrictive pattern and impaired gas exchange on pulmonary function test, basilar reticular abnormalities with minimal ground glass on CT scan, and these patients also had to have a transbronchial lung biopsy and BAL with no features of an alternative diagnosis, and they had to have at least 3 of these minor criteria, age greater than 50, insidious onset of 23 months, and basilar bivalve. The real reason I wanted to highlight this first statement on treatment of IPF at that time. And what this highlights is, one is our thought process, our knowledge has changed dramatically. And two, for us, closely related to fibrotic disease. And so the point was that treatment would include combination therapy, and that combination therapy was corticosteroids plus azathioprine or cyclophosphamide. So this is clearly not the standard of care right now, and this just shows you again how much we've learned over these last 18 years. Let's fast forward all the way to the present. The updated 2018 guidelines here. I'm doing this because I want to first talk about the diagnosis of IPF, and this is the updated statement here. And look at the guidelines. I want to focus on the patterns. In the 2011, the first actual guidelines, that we had three categories for that a CAT scan would fall under, and that would be either a UIP pattern, a possible UIP pattern, or a pattern that is inconsistent with UIP. Now, just to confuse us, we have four. And they're similar, but not exactly the same. So you can see that a UIP pattern is still a UIP pattern. What we called in 2011 inconsistent with UIP, we're now calling an alternative diagnosis. And now the possible UIP category has been changed to include probable and indeterminate for UIP. Let's expand on this. You can see on the column here on the right, this is the alternative diagnosis here. And fit in this category, the CAT scan features would include if there's cysts. These are intraparenchymal cysts, not the honeycomb cysts that I'll show you here in a second. If there's marked mosaic attenuation or air trapping, if there's predominantly ground glass opacities, if there's profuse micronodules, central lobular nodules, or consolidations, and then also peribronchovascular upper lobe distribution. Typically peribronchovascular, we think of things like sarcoidosis. Upper lobe disease, we think of things like hypersensitivity pneumonitis. Other features that actually might land you in an alternative diagnosis category is a dilated esophagus, pleural plaques, distal clavicular erosions, and pleural effusions. And this is, like I mentioned, these guidelines came out in August, and this is very new. The question which they don't really clarify is, if there's how significant of the dilated esophagus would land us in an alternative diagnosis category. If you see a distal clavicular erosion alone, does that really land us in this category? These are still being discussed. But the categories that are a little bit easier to understand, I think, are the UIP probable and indeterminate. And so the similarity across these categories is that fibrosis scarring needs to be subpleural and basal dominant. And I'll show you a picture of that here in a second. In the indeterminate category, these CAT scans may have more subtle reticulations. They may also have some mild ground glass opacities, but the key here is that the CTP distribution may not suggest a specific disease, meaning that even though, for example, there's a basilar predominance, maybe there's still a significant amount of upper lobe disease, and that would fall in the indeterminate category. Versus UIP and probable, the buzzword, the key phrase here is this honeycombing. You need honeycombing to be a UIP pattern. Probable UIP does not have honeycomb changes. So these are some examples. So the subpleural and basal predominance of this. And you can see these reticulations, which are the septal thickening here on the periphery of the lungs. And this is a subpleural predominance. This is a coronal view. Sorry, this doesn't project very well, but you can see that there's clearly a basal predominant pattern with these honeycomb changes here. Honeycombing is this. This is somewhat well defined, but still controversial. In our multidisciplinary ILD conference last week, we had a presentation from a radiologist, and the point being is that this still is not uniform. What honeycombing should be is these subpleural cysts. They can vary in size. They need to share walls here, and the definition of a cyst means that they need to have discernible walls. One point of confusion or that needs to be clarified is, do we need to have multiple layers of cysts or just one layer of cysts counts? So depending on which radiologist reads scans, they have different definitions still of this. And then lastly, traction bronchiectasis is where the airways are enlarged, such as here, and you can see the airways always follow a blood vessel, and normally the airway should be smaller than the blood vessel. And this bronchiectasis, is in the setting of background fibrosis. This is the definition of traction bronchiectasis. So based on that, I didn't go over in detail the histopathologic pattern, but it's the same category, UIP, probable, indeterminate, and alternative diagnosis. But this is how we think about a diagnosis of IPF based on these patterns. So if a patient comes in with suspected IPF, and they get a CAT scan, and you've ruled out other potential diseases, if they have a UIP pattern on CAT scan, you can see that pretty much regardless of what a biopsy would show, these patients would have IPF. That very, very, very rarely would a patient with a UIP pattern have an alternative diagnosis. To the point, if someone comes with IPF, and we have ruled out other diseases, that if they have a UIP pattern, confident clinical diagnosis of IPF, that these patients not have to pursue a lung biopsy. The key is this, though, as I mentioned, ruling out other diseases, because UIP is not always IPF. Yes, UIP is a classic pattern in IPF, but this UIP pattern we can see in diseases with chronic exposures, persistent pneumonitis, and asbestosis. And then for us, the important thing is connective tissue disorders, diseases. This is the importance of interstitial lung disease and connective tissue disease. As you all know, that ILD occurs commonly across the entire spectrum of connective tissue diseases, and potentially this is the most devastating manifestation encountered in CTD patients. This poses a significant challenge to practicing physicians, and a multidisciplinary approach is often useful. And as I mentioned, here at UW, we have twice a month multidisciplinary ILD conference where we have pulmonologists, rheumatologists, pathologists, radiologists come to discuss cases. So that's very important with these types of cases. These are the classic connective tissue diseases that we think of in relationship to ILD. So RA, lupus, sort of the myositis spectrum diseases, mixed connective tissue disease, Sjogren's syndrome, and scleroderma. So in this room, I don't need to go over the typical serologic tests, but related pulmonary disease, rheumatoid arthritis in particular, the most common manifestation here is actually a UIP pattern. Other things, yes, you can have an NSFP pattern, pleural effusions, organized pneumonia, rheumatoid nodules. In lupus, ILD is more rare, but it can happen. These patients can have pleuritis, pericarditis, pulmonary hypertension, shrinking lung syndrome. In dermatomyositis, polymyositis, precipitate syndrome, actually at the mixed connective tissue disease, and scleroderma, the classic pattern is more NSIP, but these patients can also demonstrate a usual interstitial pneumonia pattern. And in Sjogren's syndrome, the classic pattern we see is something called LIP, which is lymphoid interstitial pneumonia. This is more a cystic disease with nodules, different than what we've seen in the other patterns. Why is this relevant? So a CTD-ILD diagnosis impacts several things. One is treatment, which we get to. The big question that always comes up are, will these patients respond to immunosuppression versus these new anti-fibrotic medications? There's also that needs to be addressed, and prognosis. And this was published in 2007 here, looking at IIP, which stands for Idiopathic in the dark circles here, and then collagen vascular disease, connective tissue disease, ILD, here in these clear circles. You can see that the survival curves differ over this period of follow-up, 192 months. Improvement in survival. This is really what we think of in connective tissue diseases, that in general, the prognosis is more favorable than patients with IPF. That being said, there are these subsets of patients with more rapidly progressive and this comes up as a topic of discussion often in our clinic when these patients come in with really progressive disease. And again, this is a clinically amyopathic dermatomyositis, and often this mimics anti-synthetase syndrome. Patients can present with deep cutaneous ulcerations, painful palmar papules, and these other cutaneous manifestations. Here you can see the heliotrope rash, so the erythema is neck distribution. This doesn't project very well, but erythema and ulceration, these gotchas papules here. So amyopathic dermatomyositis, initially and pretty much uniformly, all reports discuss this rapid, progressive, fulminant ILD. If there was tissue, and typically from autopsies, this would show DID, which is diffuse alveolar damage. But more recent case reports, or more recent cases, suggest a spectrum of disease. That yes, most patients still seem to be rapidly progressive, but there are some patients that have been reported to respond to therapy. And this is associated with this anti-melanoma differentiation association 5, what we call the MDA5. So the MDA5, it's proposed as a useful surrogate marker of disease activity. There's been reports that patients with a lower titer may respond to therapy. It's not clear exactly what a cutoff would be. There's also been patients that have been serially monitored. They have a positive MDA5 at onset, and the MDA5 goes away, and these patients seem to respond to therapy. There's also the question of whether or not it plays a potential pathologic role in lung injury. And one thing that's been described is serum ferritin as a useful marker, and it's been described in several cases that a normal or low serum ferritin level is actually a good prognostic marker that these patients seem to respond to therapy. I wanted to give a real-world case though, about this MDA5 disease, just to really demonstrate how severe of a disease this is. This is a patient that Greg and I shared here several years ago. This is a 34-year-old female who presented with a rash. This was a healthy 34-year-old. She was postpartum. I think that she had given birth about 9 months ago, was still breastfeeding at the time. And so she presented in May of 2015 with just a rash on her scalp, face, and back. This was erythematous. This was a slightly pruritic rash. And she was placed on antifungal agents. She had no response. She had a scalp biopsy that was for discoid lupus. And placed on topical treatment, steroids, topical tacrolimus. She didn't want to be on oral agents. She was still breastfeeding. She was on this treatment for 3 months' time. In August, no response to therapy. So she was placed on a 10-day course of prednisone. At that point in time, she developed some chest pain, shortness of breath at the end of April. And she seen an urgent care for these symptoms. Discoid lupus diagnosis. They were wondering about SLE. She was referred to rheumatology in September, started on Plaquenil and prednisone at 40 milligrams a day. There's a CT that she had at this point in time, which I'll show you, and there was a minor abnormality which led her to referral to a pulmonologist the next month. By November, her dyspnea was still progressive, albeit somewhat gradual. She had a little consolidation on her CAD scan, so she went for Laparoscopic first, where the cultures were negative. She had a lymphocyte predominant cell count with a low CD4-CD8 ratio. Had a repeat CT scan. She was sent to the ILD clinic, the Rheum ILD clinic here on November 24th. And these dates are important. I'll show you here on the next slide, but she was sent to us. We saw her initially November 24th of 2015. The question that was posed to us was, should she have a surgical lung biopsy for diagnostic purposes? When we saw her on the 24th, she had a non-productive cough. She had ongoing progression of her shortness of breath to the point where she had difficulty climbing one set of stairs without stopping. She had a 15-pound weight loss over these 6 months. She had desaturated on her exercise walk mainly a positive Rho 52. MJ5 1 gamma were sent, but pending. And we talked about the possibility of clinically amyopathic dermatomyositis at that time. And she was amyopathic. She did not have any sort of muscle issues. We even talked about an inpatient admission to consider treatment, but she was actually group health, I guess now Kaiser patient. So the plan was to follow up closely with her group health dermatologist and start on cycloxane and tacrolimus. Wanted to follow her very closely. The very next day, she had significant progression of shortness of breath, and she was seen in the ER and admitted to the hospital. So this is her hospital course that she was transferred to the ICU in hospital for increasing oxygen requirements. She was intubated the next day, hospital day number 4. She had a repeat CAT scan, no bronchoscopy, no evidence of infection. She developed refractory hypoxemia on hospital day number 7. She required inhaled EPO. She was placed on a vecuronium drip and paralyzed. She was placed in a prone position. And despite that, still wasn't getting better. She didn't tolerate prone positioning. She developed corneal abrasion. So they put her back supine on hospital number 12. Hospital number 13, when we got reports at the end of day 5, was weakly positive. Still worsening hypoxemia. Her PEEP went all the way up to 20. She was reprone on hospital number 20. Hospital number 24, worsening hypoxemia and acidosis, made DNR. Persistent hypoxemia, bradycardic arrest on hospital number 26. So this is someone that, remember, in May of this year was completely normal. No past medical history, was doing fine. This just shows you the progression, the really rapid progression of her CAT scans here. This is just one cut. As I mentioned, the very first CAT scan, all she had was this little tiny consolidation here, blossomed on November 10th here with scattered ground glass capacities, 1129 ground glass capacities. So this is rapidly progressive. The question is, what did she get during the hospitalization? What did we treat her with? The answer is pretty much everything. So you can see on hospital aid number 1 that she was given antibiotics, oseltamivir. This was repeated later on in the hospitalization. It was pulsed with solumedrol 1 gram daily for 3 days initially, and then repulsed again, sort of around hospital number 8. She receives cyclophosphamide initially. She was placed on tacrolimus, 2 grams Q12. She received IVIG, and then she got rituximab. Despite all this, she still succumbed to her disease. And this is one case. We've had several cases like this, rapidly progressive disease. So this is something that I think we need to be aware of. This is something that if a patient comes in with a sort of cutaneous features and progressive disease, I think that we should be sending an MDA5 on these patients. From a treatment standpoint, as you can see here, we've pretty much treated this patient with everything. There's been case reports sort of addressing all of these things that we've tried her on, and again, these very small case reports. And just interestingly, as I was putting together this talk, I did a lit search, and this just came out in Rheumatology just, I believe, last week, looking at tafactinib in refractory ILD. In MDA5 dermatomyositis. One thing I didn't mention is the classic demographic for these patients is typically Asian, so most of the literature is coming out of Japan and China, which is here. And these patients in this trial, they looked at 5 patients with refractory disease. And these are patients that failed treatment with steroids, cyclophosphamide, and cyclosporin, actually, and they placed these patients on tafactinib, and 3 of the 5 patients survived. So there's new literature coming out all the time, is the point, but this is something that I think that we in this room definitely need to be aware about sending if there's a concern. Yeah. Yes. Yeah, and so this patient, was bronched prior to admission, bronch, had intubation, had a swab, infectious microdata, everything was sent. You can see that they're treated with oseltamivir as well in this patient. So So I think that was really covered anyway for progression. So, but good question. What we've talked about so far are these sort of defined connective tissue diseases with the lung involvement. And this is a good chunk of our patients that we see in the ILD, the Rheum ILD clinic, but also a fair number of patients we have this problem, which is patients that have otherwise idiopathic of clinical, serologic, or morphologic features that suggest the presence of an autoimmune process, but don't meet criteria for a defined connective tissue disease. And this has been a topic of conversation for quite some time. These are studies in the 2000s sort of addressing this. And there's several terms that have been thrown around. There was differences in criteria. There were some issues with all these terms, but essentially undifferentiated connective tissue disease, ILD, autoimmune featured ILD, autoimmune featured interstitial lung disease. But these weren't uniform. There clearly was a need to come up with some kind of guideline to help these patients. And what that was is in 2015 that the European Respiratory Society and the American Thoracic Society came together to publish this research statement. And this is what we now know as idiopathic pneumonia with autoimmune features. And this is the issue here that I was just mentioning, that we have these patients with connective tissue ILD. And then we have a larger group of patients with idiopathic interstitial pneumonia, the IPF patients, the idiopathic NSIP patients. But at this intersect, it's sort of loosely defined. These are the patients that we're sort of capturing in this IPAF criteria. And what this criteria entails is that obviously you need the presence of interstitial pneumonia on HRCT scan or lung biopsy, again excluding alternative etiologies. And these patients do not meet criteria for defined connective tissue disease, and they need to have features from at least two of these three domains, and the domains being clinical, serologic, and morphologic. And this is a busy slide, but this is the criteria here. So the clinical domain has 7 features: the visual fissuring, visual ulceration, inflammatory arthritis or polyarticular morning joint stiffness greater than 60 minutes, ulnar telangiectasia, Raynaud's phenomenon, unexplained rash on the digital extensor surfaces. As far as the serologic domain, you can see here, I won't read all these off. But one point is that if you have an ANA in a diffuse speckled or homogeneous pattern, the titer needs to be greater than 320, whereas if you have an ANA in a nucleal or a secondary pattern, it can be of any titer. And then the morphologic domain, this is radiographic or histologic patterns of NSIP, organizing pneumonia, NSIP with organizing pneumonia overlap, or LIP, which again is the disease that has cysts and nodules. From a pathological standpoint, if the surgical biopsy reveals interstitial lymphoid aggregates with germinal centers or diffuse lymphoplasmacytic infiltration, this would fit in the morphological domain. Also, they mentioned multi-compartmental involvement, such as pleural. Yeah, it's a good question, and I'll answer that by saying this is that it's fallen out of favor in the U.S. Talk to our European colleagues that bronchoscopy is still a major part of and to the point where we very rarely were performing bronchoscopy and BAL just really to rule out infection. One thing I did not talk about is in the updated 2018 guidelines that there's more of a push to go back towards bronchoscopy and BAL. So, but right now, I guess the point is that we don't use it much. I think that we should, and we should see if there's any markers that we could find that may help us. I agree. I agree. And it's now a conditional recommendation in the updated guidelines
unusual when you do look at periodontal capillary lubrication.
Yeah.
What's common telangiectasia? And then I think of more with other conditions.
Yeah. I agree. And this is, I think that that's probably one that we pay attention to the least. This is the point that I'll make is that this is something that needs to be refined. Right? That this is what we have right now. I think that there's still opportunity to look at these criteria again and really refine, what would fall into these categories, or should we blow it all up and have different criteria? That's the point. There's no ANCA. There's no ANCA. And those are all very good points. Our main issue with this statement is that UIP alone does not fulfill the morphologic domain. UIP is nowhere in this domain. And as we've just talked about, UIP is a relatively common pattern among patients with CTD-ILD, meaning that IPAF excludes this group of patients with positive antibodies with or without symptoms, because again, they only include the three domains who have a UIP pattern. This was a big issue for us, so much that our group here looked at this with the help of Megan Fellow here, and we tried to describe what we looked at and what we call our patients. And those of you that we treat patients with, I'm sure you've noticed that we don't necessarily use IPAF, and we use more of this autoimmune ILD. What we did in this study was this is a retrospective cohort study, and we looked at all the patients coming to our Center for ILD between January 1st, 2007 and March 31st of 2013. A lot of patients, but we pared it down to these 154 well-defined patients. And the way we did that really was we required patients to have PFTs at 0, 3, 6, and 9 months at UW. If they had PFTs elsewhere, which most of our patients did, those patients were excluded. And we did that because we really wanted this clean data. We wanted the PFTs done at the same place. So that left us with these 124 well-defined patients over this time frame, 15 of which fit into IPAF criteria, 36 were CTD-ILD patients, 20 was the term that we use, autoimmune ILD, and 53 of those patients were lone IPF. And we looked at these patients over a year, and we looked at their PFT data. What we found was that these patients with autoimmune ILD, and this is decline in FVC over the year. First off, none of this was clinically significant for FVC, but these patients with autoimmune ILD actually behave similarly more to IPF than these patients with IPAF. That holds true with the DLCO. The p-value is positive because in IPAF actually the DLCO improved in those patients. So you can see that the decline in DLCO for autoimmune ILD is very similar to lone IPF. And when we look at this more carefully, because the patients with NSIP patterns typically fell into the diagnosis of IPAF, that 75% of patients in the autoimmune ILD category had UIP, so it sort of makes sense that they would act similarly to lone IPF. And the point of this, and the point of what we talked about, is that IPF is really just a start, that this needs to be refined. There's many issues that have come up in regards to this classification, and the thing to remember is that this is actually just a research platform. It's a research statement. They sound like the same. And so the criteria is that connective tissue disease needs to have that connective tissue disease diagnosis. Correct. Correct. Right. And this, for example, would be a patient that has, an ANA 1 to 160, whatever pattern, or maybe indeterminate. It's not a firm connective tissue disease diagnosis. Yes, and I apologize. I don't, and that's a good point. I should. This, I mean, we often joke, this is alphabet soup, right? This is it's very confusing because we use these all these abbreviations. So very good point. I'll add a slide, but this, I agree with you. This is all very confusing. Typical three-letter abbreviations in most of what we do. So again, IPF is just a start. Really, this statement is just a research statement. It's not meant for clinical patients. The hope is that it moves us beyond the differing terms in the past, the undifferentiated connective ILD and lung dominance CTD, and that there's this recognition that there's this thought that these patients with IPAF um, will potentially evolve into a true connective tissue disease. So let's get back to the guidelines. And what we just covered was the diagnosis of IPF. We looked at UIP patterns and expanded that to MDA5, IPAF. But I want to talk about the treatment here a little bit. And this is what I call the recent path, is 2015. And first, we'll look at the 2011 guidelines. And this chart is from 2011. That this again was the first guidelines for IPF, and what they went over in the first guidelines. These are all the treatments that were studied, have been studied for IPF, both pharmacological and other. And as you can see on this slide, that there was only two interventions that received a strong recommendation for use, which is long-term oxygen and long-term patients with progressive disease. Even something like pulmonary rehab, weak recommendation for use. And the point is that the committee did not find sufficient evidence to support the use of any pharmacotherapy in patients with IPF. Updated in 2015, and there were numerous changes. First of which, what we had termed weak recommendation for use, weak recommendation against. Now they retermed the conditional for conditional against. And there's a few changes here. Important ones that I'll point out is that the combination of prednisone, azathioprine, and NAC, which had been the standard of care for years on end for IPF, had moved from a conditional recommendation against to a strong recommendation against. Study. This was the first true randomized combination. Before this was standard of care based on patient small trials. And this study was actually stopped early because that arm, prednisone, azathioprine, and NAC, N-acetylcysteine, there was a trend towards far more hospitalization. This trial was actually stopped early. The other main thing to point out, the main change is pirfenidone. Talk about move from a conditional or a weak against to a conditional for use. There were a couple new recommendations, new medications that had been studied in the interim. We listed here. The main one to draw your attention to is Nintedanib, which is the recommendation for use. And then putting this all together, that there were three pharmacologic recommendations with a conditional recommendation for use, and that was this medication, Nintedanib, Pirfenidone, and looking at the first two, which is Pirfenidone and Nintedanib, what we know is that these medications attenuate the loss of lung. So these two studies, Pirfenidone, the study was called Ascend, Nintedanib was called Impulses. These were both published in the same edition, and they show similar findings. That you can see the dark blue line here is Pirfenidone, the lighter line is placebo. Same thing here, dark blue line is placebo, and it slow the rate of FVC decline. FVC continued to get worse, so there was not stabilization of disease, no improvement of disease, but it slowed rate of decline. So this is just basic information on these medications. That Pirfenidone, as far as the mechanism, actually we have no idea how it works to this day. Nintedanib is a tyrosine kinase inhibitor. It targets VEGF-R, FGFR, and PDGFR. Dosing of these medications for Pirfenidone, it's oral 801 milligrams 3 times a day. And when we start out this medication, the tablet size is 267 milligrams to allow for expansion up. it ends up being 3 pills 3 times a day. When these patients are stable, they can eventually get to 101 milligram tablet. There's only a pill burden of 9 pills a day. Nintedanib is just 1 tablet twice a day, and that's either 100 or 150 milligrams. Monitoring is liver function tests monthly for these meds, every month for 6 months for pirfenidone, every month for 3 months for nintedanib. I have the last column in here being can continue to take when listed for lung transplant at UW because this has changed. When these medications were available in 2014, early 2015, that our lung transplant team actually did not allow patients to be on either medication at listing for lung transplant because they're new medications. We didn't know how the lung allograft would function, so they did not allow either medication. That changed in 2016 where they allowed pirfenidone, but did not allow nintedanib. Nintedanib has a theoretic risk of thrombotic and bleeding events. So that was not allowed. Just last year, they've changed their mind as more data has come out being inconclusive, and they're allowing these patients to stay on both medications at listing. There are clinical trials. You can't do it clinically now. Insurance would not allow that. The clinical trials have ended. They haven't been published yet. And that being said, it's also not any sort of formal head-to-head analyses, nor will there ever be. So what we have to look at is these meta-analyses. So the question being, does one perform better than the other? And this is from our group here looking at this network meta-analysis. And what we found was that there's really little difference in pirfenidone and nintedanib in all-cause mortality. And you can see anything to the left of the y-axis here favors treatment one. Pirfenidone versus placebo, pirfenidone is favored. Nintedanib versus placebo, nintedanib is favored, but when the two are compared to this side, falls pretty much to the axis. And this holds true. There's been several meta-analyses done, and this holds true sort of across the board. How do we decide which patient gets what medication? So we go over to the slide that I showed you before about the mechanism of action. We go over pills and pill burden with patients. But one of the main deciding factors is the side effects. And these medications have pretty predictable tolerability profiles. And this is from the Ascend and Impulses trial here. For pirfenidone, the common side effects are nausea, fatigue, diarrhea, and rash. This holds true in our real-world circumstances now. Whereas nintedanib, mainly what we see is diarrhea. And these patients in the trial, over 60% of patients in the Impulses trial had issues with diarrhea. And to the point where when we prescribe this medication now, and this is sent to the patient to a pharmacy, Imodium is actually included in the package for patients to use as needed. And then there's a question of these subgroup analyses. Any population that may respond better to these medications, and this was pooled data from pirfenidone and nintedanib, and what we see is that the loss of FVC decline, the attenuation of that loss, I should say, sort of holds true across multiple patient subgroups, and you can see across age, gender, ethnicity, severity of disease, even though one thing I should say is that these medications were studied only in patients with mild to moderate disease, so not severe disease, but across multiple subgroups, that this attenuation of loss of FVC sort of persisted. With this in mind, the question is, how can we sort of expand this? Would this work? Would these medications, do these medications work in connective tissue disease or autoimmune disease? And the question right now is we don't know. That being said, we have many clinical trials that are trying to answer that question. So broken down by sort of disease type here in scleroderma, we have both the census study and the SLS scleroderma lung study 3. Census is evaluating nintedanib. SLS is evaluating pirfenidone in scleroderma patients, I should say, pirfenidone and mycophenolate. For RA, we have something called the TRAIL 1 study, which is looking at pirfenidone. These are studies that are elsewhere that actually for amyopathic dermatomyositis in China, they're studying pirfenidone. For anti-MPO in France, they're studying pirfenidone. the Cincinnati group that has an interstitial sarcoid looking at pirfenidone for sarcoid. This is really being studied across the spectrum. As far as what we have actively going on at UW are these trials here, which are the Census, the SLS3, and the Trail 1. So I won't focus on the first one too much, Census, because that study has completed the enrollment. We're actually in the open label phase now, but again, this is studying patients on nintedanib for 52 weeks, looking at the annual rate of decline in FBC. Two studies that we have that are not either actively enrolling or soon to be actively enrolling are Scleroderma lung study 3, as I mentioned, is looking at pirfenidone, and this is looking at pirfenidone in the setting of mycophenolate. So these patients, so the intervention is mycophenolate plus pirfenidone versus mycophenolate alone, mycophenolate plus placebo. This is looked at over 18 months, and we're looking at the change in the percent predicted FVC. Some key inclusion are these patients need to be over 18. They need to have their first scleroderma symptom within 7 years of randomization, and the FVC needs to be less than 80%. Key exclusion is they can't be too sick, so they're excluded if their FVC is less than 45%, less than 30%. If they have significant uncontrolled pulmonary hypertension, and then simply studying the mycophenolate and pirfenidone combination, they can't be on mycophenolate within 6 months of the trial. Any pattern, yeah. So not just UIP. But yes, not just UIP. For the Trail 1 study, this is looking at pirfenidone, again, in rheumatoid arthritis over 52 weeks, looking at a composite endpoint of decline in FVC of 10% or greater or death. These patients between 18 to 85 with an FVC between 40 and 40 to 80, DLCO between 30 to 80, no diagnosis of other CTD, and smoking within 3 months is an exclusion. So these are studies, again, that are either actively enrolling or soon to be enrolling. If you have any patients that you may be interested, we're certainly happy to help them out. And the last thing that we'll talk about in the last couple minutes here is the last intervention that received a conditional recommendation for use, which is this anti-acid therapy. This has been well studied, especially with Dr. Ragu here, and we know that there's this relationship between GERD and IPF, that up to 87% of patients with IPF have abnormal distal esophageal acid. This is based on 24-hour pH monitoring. The exact relationship is unclear. There's two main hypotheses, essentially chicken or the egg, that either reflux is a sequelae of IPF, meaning that IPF causes fibrotic lung disease, and there's changes in intrathoracic pressure that loosen the lower esophageal sphincter, causing reflux, versus the other way around, which is sort of our bigger hypothesis, is that chronic microaspiration can lead to progressive fibrotic disease. And despite the high prevalence of GERD and IPF, only 25-47% of patients with IPF report, meaning that there's a majority of patients with systemic reflux. I don't have the exact number, but it's less than that, much less than that. So, and I want to, I want to say it's somewhere around 30%. Don't quote me on that, but if I recall, but it's much less than that. Yeah, yeah. And so, looking at GERD and IPF, we know that use of GERD medications are associated with lower radiographic fibrosis scores and is an independent predictor of longer survival. So these are Kaplan-Meier curves here. There's two of them because the first one are patients that were symptomatic, were treated with PPIs, and then when they came to clinic, they were followed and they were matched up with patients in the control group, and you can see that these patients, the curve is separated here with improvement in the PPI treated group. The same holds true here in the second Kaplan-Meier curve, and these patients that did not have a history of regular PPI use, no reflux symptoms. These are the asymptomatic patients, presumably with silent reflux. So we know that treatment of GERD, gastroesophageal reflux, is this independent predictor of longer survival. There's been studies looking at other mechanisms to control GERD, including laparoscopic anti-reflux surgery. So this is a trial that we just completed and was published earlier this year, the treatment of IPF IPF and abnormal reflux will slow the rate of decline in FVC over 48 weeks. And this was just published in Lancet Respiratory Medicine, randomized controlled trial, IPF patients with abnormal GERD based on 24-hour pH. This was 6 academic centers in the U.S., one of which being us, and we actually had the vast majority with 40 plus patients of the 58 work through our center here, and they were assigned to anti-reflux surgery versus standard of care. Primary endpoint was change in FVC from randomization to week 48. And there was a signal, although it was not statistically significant, of increased reduction in the FVC loss. Over the 48 weeks, the FVC went down by 0.5 in the surgery group versus 0.13 in the control group. I should say the standard of care group. These patients were receiving medications. And secondary endpoints were interesting as well, that fewer patients had acute exacerbations, 1 versus 4, and there were 29 patients in each group, for hospitalizations, 1 patient was transplanted in the no surgery arm. These did not reach significance as well, but there's a signal that laparoscopic anti-reflux surgery may be beneficial. This explains why we've been sort of aggressive and we've been talking about the benefits of this for a while. So extrapolated to our patients with CTD, the added risk factors that is often affected in these patients with CTD, and I think that we should consider formal reflex studies, because that's really what helps us determine is there any potential benefit in aggressive medical approach versus a surgical approach. So putting this all together, the conclusions are that UIP is a pattern that can be seen in IPF as well as connective tissue disease and autoimmune ILD. That IPF is a useful research definition, but can and actually should be refined, needs to be refined. That MDA5 dermatomyositis should be considered in patients with rapidly progressive ILD, and treatment options for IPF are being explored in patients with CTD. Questions?
How useful do you think that therapy would be to identify this patient? Because it takes us so long to do MDA5 antibody back.
Yeah.
Would that be something we could do?
I think we should. I know that we don't do it, but I think that we should add that. There's also case reports. I think when I counted, there was 5, demonstrating a similar finding. I think ferritin levels 500 were favorable. So I think it's something that's easy enough to do, especially since MDA5 well to come back, and that we should probably be something that as well. It's a good question. I'm not sure. I'm not sure. Yeah. There you go. I like it. Yes, absolutely. Yeah. Yeah, I think it's controversial. I don't think it's the current thought, but it's not others in our group. I think that's a thought that there's this thought that IPF may not exist in 5 or 10 years down the road, that this UIP pattern may be more end-stage fibrosis. So it's a thought. It certainly has not been validated.
Are there specific data on the prognosis as far as from the time of diagnosis of, say, ILD to the rapid progressive stage, when they succumb to disease? I mean, like what time frame are we looking at despite the treatment? Yeah.
We're talking, I think, in terms of months. 3 to 6 months is what's been sort of described. I think our patients, that the duration of her time course sort of fits in that 6 months, but really it was that month where she was just rapidly progressive and stuff. So I think what's generally been described is somewhere around 3 to 6 months is this sort of rapid progression.
One thing I noticed in the case of the young woman that you presented, and I've had 2 patients who had a similar course, was this idea of worsening after getting prednisone. Is that something you commonly see in patients? Because she seemed to develop her chest pain and shortness of breath in the context of getting a course of prednisone.
Yeah. That's a good point. I just think anecdotally in our patients now, I don't think I've witnessed that. I think that I can go back and look. I think, again, anecdotally, the one thing that I've seen, I think I shared two patients with Mark that are two or three surviving patients with MDA5 are on tacrolimus. So again, this is completely anecdotal, and that there's some case reports suggesting that there are sort of surviving MDA5 patients on tacrolimus, for what that's worth.
Is this a quick pathway for lung transplant specifically for those patients, or they just have the same?
No, the answer is no, and this is difficult in our program here because many times autoimmune patients, specifically scleroderma patients, are excluded because there's such a strict criteria about esophageal peristalsis in our program that any patient that's aperistaltic will not be accepted for concerns over reflux and aspiration. It's controversial. We've fought this, and oftentimes we have to send patients with scleroderma to UCSF, Stanford, Northwestern to get their lungs. And so I hope that's something that we can continue to fight. But it's oftentimes difficult for these patients with MDA5. It'd be even more difficult. Another strict criteria that our lung transplant team has is that they don't allow inpatient evaluations, right? So they will not, under any circumstance, do a evaluation when the patient's in inpatient. So.
What a lung center here.
Yeah.
That's good science. So what's been done on the research front? For example, there are circulating fibrocytes and things like that. If you connected with them, looking at your patients.
Yeah, and we want to. We hope to. We haven't. I think our group has been sort of clinical and sort of translational, but I think that now that we have, as Greg mentioned, a big cohort of us here in the ILD clinic, I think that we need to be expanding into sort of more research and basic science. So not yet, but hopefully.
I have a comment and a question. For the MDA5, again, I think it's such an important marker.
Yeah.
We're planning to add that to our myositis panel and actually to the acute pulmonary renal failure panel.
Yeah.
For the essentially when they come in with alveolitis.
Yeah.
I think it's a marker to say if they've got to treat despite looking for infection for these conditions. So make it easier to get quickly.
Yeah.
So that's the comment. The question: do you think there's something specific about ferritin and the effect of iron, or is this just an inflammatory marker? Kind of a subset of that is: are we looking for all inflammatory markers?
Yeah.
As a predictor of who to treat? Again, IPF being,
Yeah.
if it's IPF and burned out, there's no reason to treat. But
Yeah.
if it's modeled, as we talked about, maybe any inflammatory condition,
Right.
is a rationale to treat.
And it's a good question. I mean, I couldn't find anything specifically about ferritin. So I think that's a good question. We're talking about getting a database going. It's something that we can definitely ask and hopefully answer.
Ferritin is one source is macrophages, right?
Right. So,
Important cell.
And of interest related to that, in hemophagocytic syndrome and HLH, there is literature mainly from Europe that you can distinguish the source of the ferritin depending on whether it's glycosylated or not. So in the liver, glycosylates ferritin, whereas macrophages don't.
yeah.
And we actually have a potential to look at that as well.
Yeah. I don't think that's been looked at in any of these reports.
You had mentioned that the MDA5 titer might have some predictive value, and that low titer was associated with better survival.
Yeah.
Yet the patient you presented has a very low titer and obviously did not have good prognosis.
Yeah.
Are there false positives in MDA5? Mark, are we
Wait, you're talking about an autoimmune laboratory test? Do you think they're false positives?
never?
Never. Yeah, that's right. That's the answer. Never. It is relatively specific. I mean, again, there are both ELISA and line blot assays. So they have kind of where do you put the cutoff?
Right.
They're not immunodiffusion, which is inherently insensitive. So there's that trade-off.
Yeah. Question. Yeah. Agree. We certainly have a lot of patients, so I think it's very important to get a database going and answer these very important questions with our patients here.
If you do make such a slide request
excited to. I can make that slide. I actually have that slide in the presentation for me. Definitely. Yes.
No one else has to.
I can do that.
So, are you aware of any new therapeutics in the pipelines out there? Something that could be great in a year or two?
For IPF, there's several in the pipeline that are sort of phase 2, phase 3. Just here at UW, we just completed a trial, Pentraxin 2, the sort of monocyte differentiation factor, that it's been looked at in bone marrow fibrosis, and we're looking at it in pulmonary fibrosis. So that's something that's just on the top of my mind, just because we just completed that trial here. So there's many things in the pipeline that are.
You see anything that's promising?
Maybe that drug, just because I was involved in that here as a PI, so I'll go with that. But it's still it's still a ways away. Yeah. Any other questions?
So there are these induced autoimmune inflammatory conditions with checkpoint inhibitor therapies and so on. Does the lung get involved with that? I have to say, I've seen that. And the answer is it does.
Yeah.
Why? Why would I not like to pick up? Do you have any idea?
I have no idea.
Can the VAL, we were talking about this, can the VAL sort those out better than another location?
I'm not sure. I'm not sure. I think again the answer is that we've just fallen away from it so much that it's not looked at that frequently anymore. But I think that since it's part of the guidelines now, I think that it's something that we should.
So do you see patients who have had checkpoint inhibitors?
I have not.
We saw one weeks ago who had a checkpoint inhibitor, but actually got better on the steroids and was now resolving.
Okay, I think we better move on because we have another speaker. Thank you.
Thank you.
And we'll pass out evaluations at the end. For those of you at UW, please do an evaluation with Dr. Ho, and then Dr.
Yeah, I'll see what I can do. Don't worry about it. Okay. Oh, yes.